Прошу прослухати лекцію лікаря, реабілітаційного ортопеда Даніеля Вайгеля на тему про особливості ведення м'язової дистрофії Дюшена після втрати амбулаторних можливостей в ортопедії.
So now we invite you to listen to the lecture of Dr. Rehabilitation Orthopedist Danیeля Вайгеля on the topic of features of Duchenne muscular dystrophy management after loss of ambulatory capacity in orthopedic.
Даніель Вайгель, доктор медицини, голова відділення дитячої ортопедії Дитячий медичний центр Шнайдер, Ізраїль, член Ізраїльської дитячої ортопедичної спілки, Ізраїльської ортопедичної асоціації, Американської академії церебрального паралічу та функціональної медицини, учасник більше як 30 наукових заходів, починаючи з 1994 року, більше 20 опублікованих статей.
Даніеля Вайгеля, Doctor of Medicine, Head Pediatric Orthopedic Department, Шнайдер Children's Medical Center, Member of Israel Pediatric Orthopedic Society, Israel Orthopedic Association, American Academy of Cerebral Palsy and Developmental Medicine. Participation in more than 30 scientific meetings since 1994. Around 20 published articles.
Hello, good morning, everyone. My name is Danیeля Vajgel. I'm head of the Pediatric Orthopedic Department at Schneider Children's Medical Center. And I wish to thank again the organizers for inviting me to give this talk about the orthopedic aspects in non-ambulatory patients. I just share my screen. During this talk, we will mention the reasons for non-ambulation in these patients. We will speak of the typical deformities and, of course, the orthopedic management. So why do these patients stop walking? Obviously, muscle weakness, but also joint contractures that occur from two reasons are the cause for that, and I will mention this. So muscle weakness, and we speak mainly of the anti-gravity muscles, so quadriceps for knee extension, glutei for hip extension, and erector spina for trunk. Once these muscles become weak, the upright position becomes problematic for these patients, and they prefer to go into the sitting position that will cause other problems as well. So it's not only the muscle weakness that prevent these patients from walking, but the joint contractures, and we will mention two reasons for joint contractures. So mainly the static position in the sitting position that causes imbalance and therefore also contractures, but also the biological changes in the muscles. The main contractures that we see are the ankle joint plantar flexion, so equinus, knee flexion, and hip flexion. This study was looking into the typical contractures in walking and in non-walking children, in ambulatory and non-ambulatory patients. And as you can see, the ambulatory group also had a typical contracture, namely the equinus contracture, while the non-ambulatory group had more pronounced hip flexion contractions and knee flexion contractures. So the plantar flexion, the equinus position, although being pronounced at a very early stage of their ambulation, of the very early stage of the disease, does not necessarily prevent these children from walking. Actually, the opposite is the truth. And we've mentioned it in our last talk. So the equinus position of the ankles causes imbalance, of course, that may cause falls. It will slow the gait, yes, but it will not cause prevention. It will not prevent them from walking. Actually, as I mentioned before, the plantar flexion, knee extension coupling allows for knee extension. So once the ankle cannot go into dorsiflexion, the ground reaction force goes in front of the knee, and because of this lack of dorsiflexion, the knee will go into extension. So as I said, the equinus position does not prevent these children from walking. What about the knees? That's really a problem. So once the quadriceps becomes weak and the upright stature becomes problematic, these children tend to sit. And the problem is that with prolonged sitting, once they go into the sitting position, knee flexion contracture occur very fast. So at the early stages, the knees go into extension, as mentioned before. At the later stage, because of the prolonged sitting position, the knee go into flexion, and this is actually the main reason why the flexion contractures of the knees are those that prevent these children from even passive standing with support. Once the flexion contractures go beyond 30 degrees of flexion contracture, it will be very difficult to get them even passively into an upright standing position, even with support. What about the hips? As you know, in Duchenne muscular dystrophy, the proximal muscles of the pelvis are more affected than the distal, and that's why the proximal muscles of the pelvis, the hip extensors, are mainly affected, which will cause hyperlordosis. It will cause anterior pelvic tilt that will cause hyperlordosis, but also, of course, anterior pelvic tilt will cause hip flexion contractures to occur, and again, hip flexion contracture will prevent these patients from standing even in a passive way. So we all know the well-known Thomas test that shows the flexion, the amount of flexion contracture. So to summarize the positioning flexion contractures, these are not the ankle plantar flexion contracture that prevent these patients from walking, but mainly the knees and hip flexions that cause that. But it's not only the static positioning that causes the contractures. We know that there are biological changes that occur within the muscles, so mainly fatty infiltration and fibrotic changes of the muscles. The lack of dystrophin will prevent muscles from recovering, and the absence of dystrophins causes the ongoing muscle damage and replacement of the muscle fibers by scar tissue and fat. This will prevent muscles from contracting in a normal way. The muscles become very stiff, fibrotic, and short. So again, it's not only the static positioning that causes these problems, but also the changes in muscle quality. So you may ask, what about prednisone? Yes, we know that prednisone has a positive effect on strength and functioning, but unfortunately, the steroids cannot prevent these changes that occur in the muscle, and muscles become fibrotic and stiff anyway, even under treatment with steroids. So loss of ambulation is caused by muscle weakness and because of contractures of the knee and hip. At the later stage, because of the changes in the quality of muscles, and the muscles become short, and secondary deformities occur in the feet, mainly the pes equinovus, that may prevent these patients from wearing shoes. But the most problematic deformity is, of course, scoliosis. Scoliosis will appear later at the late childhood or early adolescent stage. And the problem with scoliosis, it is not only the scoliosis itself and the influence on respiratory function of these patients, but speaking mechanically, once the trunk moves sidewise, the patient needs to support himself with his upper extremity arms, which will prevent and take function of the upper extremity. So once the body tilts to the side, the upper extremity become an assisting positioning for the patient, and he cannot use them for other purposes. So obviously the orthopedic management of these patients is mainly to prevent contractures at early stages. This can be done only with an interdisciplinary team. We try to maintain the spine as straight as possible, minimize joint contractures, and of course fracture management. We will talk about that. So we need for that physical therapist, occupational therapist, rehabilitation physicians, social workers, and so on. So at first, physical therapy, stretching, using of orthosis, getting these patients into standing position as long as possible in order to try and prevent as long as possible the contractures to occur. The problem is that once these patients become non-ambulatory, there is a fast deterioration in their muscle strength as well. As I mentioned before, fast development of contractures, hips and knees, and actually it will fail, any surgery will fail to get them into the upright position. There is no way we can cause a non-ambulatory Duchenne muscular patient to walk again, even using surgeries. In fact, we talked about this in our last talk, that nowadays we have, there is a tendency towards more conservative attitude, and it was shown that patients who underwent multi-level surgery in order to try and get them into a prolonged ambulation state did not believe that these surgeries helped them at all, and would not recommend doing these surgeries again. There are many other factors, not only weakness and contractures, that prevent these patients from being ambulatory again. Obesity is one of the main reasons, but also state of mind conditions and motivation. So to summarize, the surgical treatment of contractures, generally speaking, there is a trend to go into a more conservative way, try to use braces if possible. In our last talk, we mentioned this task force that was established to define what are the orthopedic treatments for Duchenne muscular patients. And as you can see at the end, early non-ambulatory stage or late non-ambulatory stage, there is actually no recommendation to perform any surgeries. We might speak of doing feet surgeries for those patients who suffer from deformities, which may prevent them from wearing shoes. So we can do Achilles tendon lengthenings, tibialis posterior tendon transfers, and so on. This may allow them to wear shoes, but many patients, despite these contractures, declare that they are asymptomatic and they are not willing to go these surgeries. So whether to do a surgery for their feet or not should be very individualized. So of course, this is not the case with scoliosis. With scoliosis, we have to be very aggressive regarding surgeries. We know that conservative treatment with bracing not only cannot prevent scoliosis from getting worse, but actually worsen the pulmonary function of these patients. So bracing should not be used for these scoliosis patients. So what about steroids for scoliosis patients, for Duchenne muscular patients with scoliosis? Yes, definitely, these have made a huge change. It had been shown that the Deflazacort causes a decrease in the incidence of scoliosis. Patients who were treated with corticosteroids can develop scoliosis, but the progression is less predictable. And before doing any intervention, we must prove that there is a deterioration. So a period of follow-up to show this deterioration is necessary before intervening. This is not the case in patients who are not treated with steroids, in whom we know that once scoliosis occurs, it will definitely rapidly progress into severe scoliosis. The problem with scoliosis, of course, is the pulmonary function that deteriorates, and therefore we have to operate these patients soon before their respiratory function goes down below 30 or 40% of normal functioning. So usually we don't wait for scoliosis to get worse than 30 degrees. Once they reach 30 degrees or their vital capacity deteriorates, we have to go and do the surgery before they go into a very difficult respiratory condition. So recommendations for orthopedic surgery, as I mentioned, once we see scoliosis, these patients need to be observed by orthopedic surgeons. And if the scoliosis deteriorates or their pulmonary function goes down, we need to perform the posterior spinal fusion. The goals for the objectives for doing a posterior spinal fusion is first to prevent progression of the scoliosis, but this will also improve significantly their sitting position. As I mentioned before, the upper extremity are become free. It may reduce pain, and in some studies it was also shown that posterior spinal fusion improved respiratory function in these patients. Usually, if the pelvis goes into obliquity, the fusion will be down to the pelvis. So even though we are not sure about the improvement in respiratory function, there is no question that posterior spinal fusion has a positive effect on the function, sitting, balance, prevention of pressure sores to appear in the pelvis region. And it had been shown that posterior spinal fusion in neuromuscular patients has a positive effect on quality of life. So towards the end of our talk, I will mention the problem of fractures. We know that Duchenne muscular dystrophy patients suffer from fractures. This is because of muscle weakness that causes them to fall, but also bone mineral density is low in these patients. And the main problem with patients, according to this study, they showed 48% of ambulatory patients having fractures, but 25% of these patients actually lost ambulation after healing of fractures. Yes, again, steroids have a positive effect on bone mineral density, but still the lower extremity weakness and bone quality causes these patients to have more fractures. So in ambulatory patients, we tend to be more aggressive. We treat these fractures aggressively with surgery to allow, again, reambulation as fast as possible. But in non-ambulatory patients, we tend to operate less on these fractures and treat them in a more conservative way, either immobilization, braces, and so on. So I wish to thank you again for giving me the opportunity to give you these thoughts about orthopedic treatment in non-ambulatory patients. And I think this is time for questions. So thank you again.
Hello, and good afternoon. I'm Dr. Sharon Ronnie from the Neuromuscular Clinic, and it's a pleasure.
Дякую, Даніелю. Ви з нами на зв'язку. Зараз я хочу уточнити, Дмитро Головатюк є в нас на зв'язку? Якщо є, включіть мікрофон, дайте знати.
Thank you, Daniela, for your presentation. We are very glad to see you right now.
Yeah. Hello.
And we'll check one more person. And again, we welcome Mila Gumanovsky, who will translate all your questions.
Hello.
And answers.
Hi.
В мене питання. Скажіть, будь ласка, в якому випадку ортези необхідно застосовувати обов'язково, а в якому випадку ортези протипоказані?
The first question is about the orthosis. So, in which cases the orthoses are recommended to be used at children with Duchenne, and in which cases it's forbidden?
So I would say that it's not forbidden to use these braces, but from our experience, the patients don't really tolerate braces. We tried at first to use braces for ambulatory patients, and we used ankle foot orthosis to assist them in walking, and they actually preferred to walk without the braces. It was easier for them to walk on their toes than use the braces that forced them down. Should I wait for translation?
Yes, thank you. Okay, sorry. То, что доктор Вайгель сказал, это что нет такого, что запрещены ортезы для детей. И то, что они заметили, что дети не любят ортезы, и как бы сначала рекомендовали больше для детей, которые еще амбулаторные. Вот, но детям было очень сложно ходить в ортезах, и они предпочитали ходить на носочках. И то, что как бы он показал в лекции, что ходьба на носочках им так облегчает вообще способность ходить. Поэтому постепенно они перестали настаивать на ортезах. Вообще они не настаивают на ортезах, которые используются в течение дня, то есть тех, которые ходят в обуви вместе с этими ортезами, больше для ночи, как бы ночные ортезы. Вот.
And thank you. And the reason that they could not use the braces was because of their equinus. The equinus position of the ankle became worse even during using of braces. So it caused pressure and pain. So that's why they just dropped the idea of braces and preferred to walk without them.
I will translate, thank you. То, что доктор Вайгель говорит, что часто, несмотря на то, что дети носили ортезы, вот эта вот позиция голеностопа, как бы изгиб вот этот, он все равно как бы становился больше, даже если они его использовали. И таким образом, как бы дети использовали большую боль, как бы используя и ортезы. Поэтому, то есть, дали возможность им ходить, как они могут на носочках.
Now there is the question of using braces in resting positions, even for non-ambulatory patients. So for a time, we tried to use night splints, night orthosis, not for walking, but for posture maintenance. And some kids could tolerate these, but to be honest, we did not see that these prevented contractions to occur. So even if they used the braces, and not all of them could tolerate them, we did not see any significant prevention of contractures. And this is supported by the literature also.
I will translate. Теперь насчет ортезов, которые используются во время отдыха, например, такие как ночные ортезы. Эти ортезы специально сделаны для того, чтобы предотвратить контрактуры, но то, что они увидели, что дети тоже их не очень любят, но даже те дети, которые их использовали, все равно контрактуры они происходили. Вот. И таким образом, то есть это было не только в медицинском центре Шнайдера, это также как бы есть другие статьи медицинские на эту тему, что это не предотвращает совсем контрактуры. Это их замедляет, но не предотвращает.
As I said in my talk, the main reason for contractures is not only positioning, but also the changes that occur within the muscle itself. So because of biological, and that's why I believe that the braces cannot always help.
I will translate, thank you. То, что говорит доктор Вайгель, что как бы главная причина того, что как бы контрактуры происходят, это не только из-за позиции и из-за того, как дети ходят, но также, как это самое очевидно, из-за изменений в строении мышцы, которые происходят при этом заболевании.
So I hope this answered the question. Yes.
Он надеется, что это ответило на вопрос.
Дякую велике. В нас є запитання. Руслан Пащенко, прошу вас.
We have a question from Ruslan Pащенко.
Мікрофон увімкніть, будь ласка. Руслане, ми вас не чуємо.
Руслане, спробуйте.
Доброго дня.
Дякую.
Good afternoon.
Шановний Даніель.
Shalom, shalom.
У мене до вас є запитання стосовно ортезування деформації хребта, в частності сколіозу. Чи використовуєте ви ортези Шено і ортези на хребет для сидіння? От такого плану.
The question from Mr. Pащенко is about the braces for scoliosis. If it is used, are you...
Ортопедичне сидіння.
Скажите еще раз.
Ортопедичне сидіння.
And some orthopedic specific for sittings. Вы имеете в виду кресла ортопедические?
Да.
Okay. Like orthopedic chairs and all what happens to this.
Yes, so first of all, braces. I think he mentioned the Shanu brace, which is also very common in Israel, but this is mainly for idiopathic scoliosis. So for neuromuscular scoliosis in general, and for Duchenne muscular specifically, the rigid orthoses don't prevent scoliosis, okay? Don't prevent the progression of scoliosis. I will let you translate that. And
Окей. То, что доктор Вайгель говорит, что вы, скорее всего, имеете в виду шану, правильно, ортезы? Шану ортезы. То, что он говорит, что они подходят больше для идиопатического сколиоза, но здесь имеется в виду нейромускулярный сколиоз. Таким образом, ну, как-то твердые ортезы, да, они не предотвращают появление сколиоза в этом случае.
so that's why we use soft braces. And also, as you mentioned, chair positioning, chair support, so support in the chair, custom made, just for the reason to support the patient, not to prevent the scoliosis, only to give support. We know that rigid orthoses are can cause pressure sores and actually cause difficulties in breathing.
Окей. То, что он говорит, что лучше для таких пациентов это мягкие ортезы. И как вы сказали, что в креслах, что как бы даст приспособление в креслах, это поможет. Но здесь важно понять, что приспособление для того, чтобы улучшить положение, поддержать самого пациента в кресле, но не чтобы предотвратить сколиоз. То есть имеется больше для удобства и чтобы как бы облегчить пациенту. Жесткие ортезы.
Освободить руку.
Да.
Освободить руку при сидении.
Я сейчас секунду спрошу это. То есть жесткие ортезы, они могут навредить тем, что могут как бы еще больше затруднение дыхания. Вот, то есть есть как бы еще проблема с дыханием, с тем, что объем мышц уменьшается, то есть это может как бы усугубить ситуацию в этом смысле. А сейчас я спрошу насчет освободить руку. Dr. Weigel, the question is about the chair with the soft, not
Support.
Soft support. If it is a chair should like allow to use more free hand of the patient, what is the main reason for the soft support? Is only for the comfort, or it's also some, I don't know, kind of to be more freely in movements?
Both answers are right. So first, he has to feel comfortable. This is very important. So no pain and no pressure. But good support of the trunk allows free usage of his hands. That's true. So I would say that both objectives are very important. So also support for comfort and support for function. Both are very important. I agree.
Окей, то, что он говорит, да, что важно здесь две цели в таких креслах, как это сам, во-первых, чтобы было просто удобно, и чтобы было меньше боли, и как больше просто комфортно. А второе, да, это чтобы как бы, ну, лучше, чтобы сидение было лучше, таким образом, да, он больше, как бы сам пациент может больше использовать свои руки и как бы более функциональный быть, используя такое кресло.
Спасибо, Даниэль.
Thank you, Dr. Weigel.
Thank you.
У нас є ще одне запитання до Даніеля. Прошу.
We have one more question.
Скажите, пожалуйста, меня интересует такой вопрос, как мамы ребенка с Дюшен. Ортопед назначает конкретные ортезы индивидуально для ребенка. Какие потом дальнейшие действия родителей? Индивидуально потом подбирают эти ортезы уже ортезист к ребенку или так продолжает заниматься доктор-ортопед с ребенком?
The question is about the routine in choosing the orthesis. So usually orthoped give the recommendation for a specific kind of orthesis. So what is the next? Does the family go to the specialist who perform this orthesis, and what should be the next steps and the follow-up of the procedure? Who is the specialist and what are the just routine who do what? I think that's the question.
So I guess depends on the structure of the services in the state, but in Israel we have, I would say about, let's say, 5 workshops, well-known orthopedic orthotists, so technicians, orthotechnicians, that they can build orthoses according to my request. So I can ask for specific orthoses to be custom made. Some orthoses can be found on a commercial basis as products that are already made, so shelf products, like knee immobilizers, braces for straightening the knee. They don't have to be custom made, they can be bought as they are. So they are shelf products that you can get ready already. But if I need a specific brace, I need to refer the patient to the orthopedic technician. They are outside my hospital, unfortunately, so they have to go to these companies and do take measures and build a custom-made brace.
And then the follow-up is with you, right? You make the follow-up. Okay, and how often?
Usually we see them every 6 months. And take, mainly for the spine. We look specifically for the spine, especially in the non-ambulatory patients.
Yep, I understand, will translate, thank you.
Sure.
Окей. То есть зависит, как бы сама процедура, она зависит от того, как это происходит, ну, как бы в каждом государстве. В Израиле обычно ортопед, он тот, кто назначает вид ортезов, индивидуализированный вид ортезов. Потом в Израиле есть 5 лабораторий, которые делают именно индивидуальные ортезы. Иногда в определенных случаях можно купить уже готовые ортезы. Например, для того, чтобы стабилизировать колено, его закрепить, не обязательно идти и делать индивидуальный ортез. Для этого можно купить уже готовый, который подходит по размеру. Что да, впоследствии ребенок наблюдается у ортопеда, обычно каждые 6 месяцев как бы смотрят, что происходит. Но в основном ортопеды как бы для неамбулаторных пациентов, они больше наблюдают за спиной. Больше фокус на...
Еще один вопрос. Дети с Дюшен даже в маленьком возрасте, они часто спотыкаются и падают. Чем становятся старше, тем они чаще спотыкаются, и риск переломов у них становится больше и больше. Есть ли в Израиле какие-то приспособления для безопасности таких детей? То ли что-то одевается на тело, чтобы смягчить боль при падении?
The next question, thank you. The next question is about safety. So small children who develop with the time, they start falling and they have fractures, as you mentioned in the lecture. So Margarita asks if any specific devices to prevent falling in Israel.
No, I'm not aware of specific things. To be honest, no, but I'm not against using wrist braces like they do for skating and knee cups, knee braces to protect their knees. But this is not routinely done. I mean, if the parent would ask me, I would say, yes, why not? You can use these, but these are not routinely prescribed.
Okay, thank you. Он говорит, что что-то специального, как бы нет такого что-то специального, что дети используют все. Лично он не против, например, чтобы дети использовали, есть разные, как такие жилетки, которые как бы используют скейтеры, или наколенники, которые предотвращают вот тех, кто катаются, да, что от падений. Именно в центре Шнайдер не дают рекомендации как бы специально это использовать, но если, допустим, родители спрашивают, могу ли я это как бы использовать для своего ребенка, говорю, почему бы и нет, да, это хорошая идея.
Дякую за запитання. Може, ще є запитання в когось? Дякуємо, Даніелі. Дякуємо,
Dr.
Міла, за
Вайгель.
переклад.
We are
Thank you for
very thankful to Daniel and Mila